Welcome back, everyone, to Einstein's Eyes. It's great to have you here. Our audience, once again, back in action. We are going to have an insightful discussion with Andy Valenciano, a friend and former classmate from HKS, the Kennedy School. We're going to explore the healthcare system from the country of Costa Rica. This is a secret gem for healthcare, and we're going to learn a lot today about how they balance health and economics, and it's really a fascinating story. They have a wonderful system with great safety nets, take care of their people. But first, I want to say hello. Carl Rosen, oculoplastics, neuro-ophthalmology, primarily oculoplastics now at Ophthalmic Associates in Anchorage, Alaska. And my friend and partner in crime from way back at Albert Einstein, John Ditkoff.
Hello, everyone. I'm John. I practice general ophthalmology, specializing in cornea. Been in practice for 30 years in northern New Jersey, about 20 minutes outside the city. And Carl and I met originally at Albert Einstein, where we did our residency, hence Einstein Eyes. So it's nice to see you, and I'm excited about a very different topic today. So I'm very excited to hear about it.
Right. But not only is Costa Rica beautiful, but like I said, its healthcare system is really top notch. And so Andy Valenciano is the director for ECLAC, which is the Economic Commission for Latin America and the Caribbean, basically promoting economic, social, and environmentally sustainable development for Latin America, the Caribbean, in conjunction with the United States and Canada. Did I get that right, Andy?
That's a great summary.
So let's kick it off, Andy, with just perhaps a little description about the geography. We know that Costa Rica is sandwiched between Nicaragua and Panama, but what can you tell us before we dive into the healthcare system?
Absolutely. Well, first of all, thank you very much, Carl and John, for the opportunity to share as you just described, this amazing case study that Costa Rica offers in terms of health outcomes. Thanks a lot to its history and the development of the primary care system in our country. So in order to understand where it comes from, I think it would be good to provide a little bit of background history on it. And it will take us, and I'm gonna be brief because this takes us back to 1940s. So in the 1940s, two very critical things happened in Costa Rica. So Costa Rica is a small, as you said, country. It has 5 million people living in it between Nicaragua and Panama in Central America. And in the 1940s, two critical things happened that shaped the outcome of our economic and health and social development in the country. The first one was in the 1941, the Caja Costarricense del Seguro Social, which is the bedrock of the Social Security in Costa Rica, was created. And then I want to explain what it has evolved into, because it really is at the heart of this discussion. But then something really interesting happened in 1949, which is Costa Rica abolished its army. So since 1949, 48, 49, Costa Rica doesn't have an army. And why do I mention that? Is that because a lot of the funding that through the 20th century, many other countries in Latin America and other parts of the world used for the development of an army, Costa Rica used those funds to basically channel them to Social Security, health, and education. So it immediately changed the social contract. So in the 1940s, like I mentioned, Costa Rica made this bet about, okay, we're going to have a security agency to provide healthcare and pensions. And it started with people who were actually employed. But at the heart of it, they said, the principles of solidarity, equity, and justice were embedded in it. And then as the institution evolved through the 1960s, that's when Costa Rica said, you know what, this has to go beyond just people who are working. We need to provide universal health coverage. And that has to be like a defining feature of our system. So at the same time that was declared, this was an amendment in the 1961, actually. At the same time, Costa Rica founded its Faculty of Medicine in 1961. So it allowed us to train doctors in country and not have to send people abroad to be trained to come back. And then at the same time, in 1961, that was a very transformative year, we created what is called the IEA, which is basically, it's in charge of aqueducts and sewers. So a lot of the sanitation efforts also were moved ahead by this other institution. So when the 1970s arrived, a couple of really interesting things happened. First of all, by that moment, La Caja, which I mentioned that was founded in the 40s, basically did the financing. But you had a lot of different providers, which is a big challenge. As you know, in the US, when you have a lot of different health providers, private clinics, clinics that are run by the church, NGOs, stuff like that. So in the 70s, through what was called a Hospital Transfer Act, all the hospitals that were operating in country were basically channeled and controlled by La Caja. So basically now, La Caja was integrating hospitals, clinics. It was also funding them. So it's a combined payer and delivery system. And again, this is one of the lessons learned that I'm sure we can talk more about it. So by the 1970s, we had also a couple of additional things that was very pioneering, which was the Rural Health Program and Community Health Program. To be very brief, those two basically recognize that the attention and the treatment of people had to be done at the community level to be able to reach those who were not necessarily going to be served by hospitals. So that those policies that were built one upon the other, if you think about it, they were even before the declaration of Alma-Ata, which was in 1978, this big declaration by the WHO that said, you know what, we need to pay attention to primary care. We need to make primary care central. By that moment, 1978, Costa Rica already said, you know what, we've been doing that for a while. Actually, most of our investments were in that line. So, and this is the last stage that I want to mention before I open it up for a discussion between the three of us, but that evolved eventually to the 1990s when Costa Rica made the last step in the transformation system, which was the creation of what we now know of as EBAIS, which are integrated primary healthcare teams. So in the 1990s, we already had a huge crisis, economic crisis in the 80s. And this was a crisis that it's called the lost decade for not only Costa Rica, but for many countries in Latin America who experienced a deep economic crisis because many countries defaulted on their debts. It was a huge challenge economically and socially. And it also pressured like the delivery of healthcare throughout Latin America. So after the 80s, Costa Rica recognized that we needed to do like another big push towards primary care. And through a very, and I can speak more about this, difficult discussion with the World Bank, Costa Rica at the end was able to get the funding to create this EBAIS. And EBAIS basically what the idea was, you know what, we're going to create clinics. And each clinic is going to have a multidisciplinary team consisting of, it had one physician, one nurse, one medical clerk, which would be in charge of like medical records, a pharmacist, and a critical figure called an ATAP, which is a technical assistant. And the idea was for this clinic to be able to provide comprehensive primary care to a population, in that case, it was between 4,000 and 5,000 patients. And it would be the first point of contact and basically the way to serve the whole population through primary care. So, and I can speak more about how the EBAIS are set up and why that has been central, but that has been the history of how Costa Rica came up to have what are now much better health outcomes than most developed countries using way less resources. That's a very critical part. We've been able to have health outcomes in terms of child mortality, in terms of maternal mortality, in terms of life expectancy that are much higher than countries that spend twice, 3 times, 4 times, 5 times as much as we do in healthcare. So that has been the history of it. And I think that I can explain more about how the advice teams are working nowadays, because that explains a lot of this comprehensive primary healthcare approach.
Right, right. So Andy, thank you. So, when I did my research, I did notice that exactly what you described, those teams that come together and make the system, function like a Swiss watch. It seems that it's great because, according to the UNDP, which is the United Nations, the life expectancy in Costa Rica is actually higher than the United States, embarrassingly. And, I mean, again, this is the best kept secret. However, I will say that word is getting out because medical tourism is starting to flourish. And, I believe that, you have well over, I saw one data point that, maybe 15 years ago, you had 150,000 foreigners, and I know it's much higher now, that come in for medical treatment because it's attractive because, well, first of all, attractive to the United States because of the geographic proximity, but the high quality of medical services and the lower medical costs, so people can go to Mexico, but there's some stories that weren't so great, so they just drift down Central America and wind up in Costa Rica. And to get great medical care. And as you said, primary care is outstanding. Immunizations are really just cover virtually everyone, prenatal care, wellness, well baby visits. You guys really have it down. You've thought it out really nicely. I do wonder though, with the new technology, particularly artificial intelligence, which is really more in the large institutions like Cleveland Clinic, Mayo Clinic, Kaiser, Stanford Med, et cetera. It hasn't drifted into the communities yet, but do you know of any discussion how they're going to tackle the new technologies, maybe to assist and get to those rural areas? Any thoughts on that?
Absolutely. Actually, we have also an advantage in that sense. Given that this system of advice and the way it works is that every Costa Rican it's a system of impalement. So every Costa Rican is assigned to an advice. And because, like I mentioned, there is a medical clerk and there is a medical record for each individual that we have been able to get, not only because of the visits that Costa Ricans do to the advice, those clinics, is because I mentioned there's a figure of the ATAP, the technical assistant. So this ATAP actually does home visits. And they are stratified according to risk, which means if you're a high-risk individual, the ATAP will visit you 3 times per year. If you're on a mid-tier, it will visit you twice per year. And if you're a low risk, it will visit you one per year. But when the ATAP nowadays, and this was something, these visits, can you imagine back in the day, they were carried out with paper records. So, writing down like all the description, socioeconomic description, not only of the individual, but also of the household. With technology, now we have something that the project started in 2010. It was finished in 2018. We have a single electronic medical record for every Costa Rican in the country.
That's what the United States is trying to do.
Can you imagine? You can do that, and there's many examples of cities and communities, but having it in a single medical record. Now we have in Costa Rica, 70% of households are georeferenced. And georeferencing is not only where the household is located. I'm talking this household, this record carries information around the housing conditions, whether you have access to water, what type of roof you have, are you using cooking fuel or are you using gas? Do you have people how many kids do you have? Are there pregnant women there? What's the vaccination record of the family? Are there any chronic diseases? What has been the prescribed medications and the records for that? Can you imagine? For 70% of the households. So that means that we have information that is integrated within the system, meaning that if I'm an individual who have been visited by an ATAP, which they have my record, my vaccination record, if eventually I visit a hospital for specialized care, they can open my record and they know where I am. So if you think about it, this is for that data mining, for planning, for administrative purposes, for forecasting, to understand like an epidemiological transition, whatever you want. This is a gold mine because you have basically most of the population, you have their vaccination records, you can understand the trends in mortality, morbidity, you can really, really plan ahead. So as you can imagine, there's been a lot of universities, Ivy Leagues in the US and other parts of the world who are really interested in getting into that database to try to, do all types of research. So definitely, artificial intelligence will play a big role in how to use that data to anything from planning, well, where should I build the next clinic? Where should we invest more on, let's say, chronic diseases? How are they evolving? That's one of the big challenges moving ahead for our healthcare system, because I spoke a lot about primary healthcare, but chronic disease is growing. The deaths from cardiovascular and from cancer diseases have been growing in the country. And you know that those require sometimes specialized care, specialized interventions. So how do we plan for that transition? Definitely AI and technology play a role.
Right. So I'm jealous, Andy. I got to tell you. So the
I'll bring out a couple of things though.
Yeah.
So, we talked about the mortality rates. I mean, obviously we both know that as an infant mortality, but also duration. When I was in Costa Rica, and I've been there several times, when I've met Costa Ricans, they make a big deal out of the blue zone.
Yeah.
So, Carl, are you aware of the blue zone?
The blue zone has to do with the quality of healthcare, and that and the fact that I might be wrong, John. So I don't know for sure, but I seem to recall if you're over 100 or
There's
patients over 100.
But they live a certain lifestyle. It's also there's a much higher. I mean, correct me if I'm wrong. My understanding is there's a much higher population that eat plant-based diets there. So most people feel that plant-based diets will also decrease a lot of these diseases and decrease mortality rate, or improve mortality rate. And then you also have people there. I find they don't drink as much, they don't smoke cigarettes as much. There is a healthier lifestyle in Costa Rica that I've experienced. I mean, correct me if I'm right or wrong on any of these, and tell us about the blue zone.
Yeah, so Costa Rica has one of the, I believe there are 4 or 5 blue zones in the world, which is this small geographical areas that have a disproportionate amount of people that live way beyond 100 years. That there's very high levels of life expectancy, and they've been stuck these areas. I mean, there's one in Italy. I know there's one in Japan, in Okinawa. I believe there's one in California, and there's one in Costa Rica and they've been highly studied because of the interest they draw of what is happening that is driving these people to live so long. And at the end of the day, the answer is that it depends on a lot of factors, right? Diet has been one of the factors, but I think it's summarized like you were saying, John, like lifestyle. It's a lifestyle of people there. A lot of it actually has to do with social connection, like the relationships that people are able to keep and build, the social contacts in their communities, the lifestyle around, walking and in contact with nature, and obviously dieting. Those things play a big role. Interestingly enough, for example, if you see Costa Rica in terms of per capita income, this blue zone is located in an area where it's actually relatively poor. And that's not intuitive. A lot of people say, there's probably an area where only very rich people, right, live and they can afford this type of lifestyles. Is not the case. So Nicoya, this is the name of the blue zone, is actually a part of the Costa Rica where it has a relatively low per capita income. So it's other factors beyond income that are explaining that people live a Higher. Well, Costa Rica in general has life expectancy that is higher than Latin America and higher than the US. But this part of the country actually exceeds the national rate of it. Yeah.
Yeah, that's
How far
great.
is, do you know where Punta Lita is? Have you ever heard of that?
Yeah.
How is that near Nicoya? Which is
Yeah. That's very near. Yeah.
yeah, because that's where I stayed.
Yeah. Yeah. So
And that's where I'm going back. So maybe I'll live, an extra couple of months if I keep visiting.
Well, John,
you're gaining extra years.
the other thing to do is just, just change your birth certificate. Just add, roll it back 10 years. But no, seriously. So Andy, I'm jealous again, but when you have a smaller population, I mean, I do think it's easier to allocate medical resources,
Yes.
data driven. But the fact that you have, and states try to do this here in America, and the health information exchange, we try to do this in Alaska, and I got to tell you, they spent millions of dollars, and it really kind of went nowhere.
Yeah.
So it just seems like people keep trying, they bring it up, but Costa Rica actually did it, and I don't want to be overly critical to my fellow compatriots in America, but maybe we should look at the Costa Rican model, and maybe we'll be able to get the fuse lit with this recording. But yeah, so I really salute the the Costa Rican medical community for getting this going. But tell me, so how intimate though was government, medicine, trade, economics? I mean, how did it all come about? I mean, was there a launching point? Did it happen organically, or can you speak of that?
Yeah, so like I mentioned, that's why I started the story back in the 1940s, right? Because to explain the good outcomes in terms of health, you can tell a similar story in terms of education, at least up until the last century, like in the 20th century, where you had a big bet on developing human capital. Because Costa Rica, as I mentioned, no army. We also are a country that is not endowed with oil or gas or minerals. So basically, we realized that at the end of the day, we had to bet on our people. That was our way of developing the country, right? So a lot of investment in healthcare, in education, eventually led us also to recognize that this model, this economic model of a small country like ours with a small domestic market required us to look to the world, right? To connect with the world. And after the crisis that I mentioned, actually in the 80s, the big crisis in this last decade of a lot of fiscal distress, poverty rates went through the roof. It was a very complex decade for us. We realized that we needed to transform a model through an export-driven economic model. And that's where Costa Rica really opened itself to the world. And the way that we open ourselves to the world, to trade agreements and everything, at the bedrock of it was like, listen, world, we're not only going to open ourselves to export and import, but if you want to invest in Costa Rica, the number one thing that you're going to get here is a high-quality labor force. And then the rule of law and the democratic stability. Because if you can imagine, if we had a abolishment of the army in the 1948, since then, Costa Rica has been and is still considered one of the most strongest and longest standing democracies in the world. Actually,
Wow.
it's considered, is one of the few around the world that is considered like a full democracy by most of the international observers and indicators and surveys. And it has to do also with this building blocks that I mentioned around investment in social security, in education, in no army, that eventually led Costa Rica to open itself to the world through trade, saying, if you invest in Costa Rica, you're going to have rule of law, you're going to have stable democracy, clear rules of the game, but also a highly educated and healthy workforce. So as you can see, these are all pillars moving together, right? It's all a bet on how to develop a country. And then tourism, as you rightly pointed out, has been historically a big part of it. And not only tourism, recreational tourism, more and more in the last few years, tourism has evolved towards not only adventure tourism, but also well-being tourism, medical tourism, like these niche areas of tourists that are looking not only, yes, to see the mountains and the beaches and the waterfalls, but also to do the yoga retreat and eat organic and have like this lifestyle retreat type of tourism, but also medical tourism because of exactly what you mentioned, lower costs,
Right.
with good services, well
Yeah,
connected to the
30
US.
years ago, 30 years ago, my father-in-law's wife went there to have her lids done.
Yeah, yeah. I mean, you could
Cosmetic
stay,
surgery.
yeah, you could stay for,
Cosmetic surgery.
yeah, yeah,
That was 30 years ago. So, I
yeah.
mean, it's exploded since then, I'm sure.
Yeah,
Yeah.
so oculoplastics or plastic
Right.
surgery in general. Yeah, so that's great. But so I did want to circle back though. So, if you offered a stable democracy, a safe place, and um, if your people can get medical care too, obviously, older folks will drift in and um and really migrate to Costa Rica
There's a
potentially.
lot of Americans retiring there now in different areas that I've met.
Yeah.
How does it work for them? Do they have to pay for healthcare? I mean, do they have to get insurance? How does that work?
Yeah, so that issue is an interesting one. One, because Costa Rica is a net recipient of migrants, right? Which is very different to other countries in Latin America, which are
Yeah,
sending more people abroad than they
sure.
are receiving. So, for example, the fact that I tell most of my friends here in the US is that there's actually more US people living in Costa Rica than Costa Ricans in the US, right?
Yeah.
Because, and not only they visit as tourists, but then they stay when they retire or they invest, they become investors in the country. And, so the way that Social Security is funded, it is required. I mean, the way that the Caja, which is again the single payer and single provider of services, of health services in the country, public services in the country, is financed basically through a contribution of workers, employers, and the government. So the three of them provide the funding for the core operations of La Caja. But there's also a fund for, it's called the Régimen No Contributivo, which is for those individuals that can contribute. People with disabilities, the elder population, that they can contribute to the system, there is a fund that helps them. But when you're, for example, you can have a voluntary insurance system in Costa Rica that you can pay to be able to contribute as well. For example, if you're a consultant or you're providing, you're a retiree, you can pay this voluntary contribution that helps fund the system. The interesting thing and the challenge that we have is because Costa Rica has for many years invested in this primary healthcare. Now our challenge moving forward is that on the specialized system, let's say on the hospital level, the tertiary hospitals, there are long wait lists for receiving specialized care. And why is that? Well, one is because, as I mentioned, the epidemiological transition is one, but waiting lines have become one of the main complaints of people in the healthcare system. So you can wait up to 1 year, 2 years, even for some operations and procedures, because people realize that if they wanted to get surgery, I mean, they wouldn't get surgery at the primary care clinic. They would have to be referred to a hospital. And because people didn't want to be referred to a hospital, they went straight to the emergency room. So there's data that shows that a lot of that almost half actually of the emergency room visits are not for real emergencies.
Right.
So it's a lot of pressure to the system because people want to get treated, and actually they could be either be treated at the primary care level, or they need to be a better execution and operation and planning on the wait lists for the specialized procedures. Otherwise, there's going to be a lot of continued pressure. And this pressure, again, is by people of all walks of life. Sometimes it's individuals from high levels of income that are actually wanting to go directly to the emergency room. It's migrants, it's individuals in rural areas, it's everyone. So it's a big challenge, especially for our growing population and aging population, that we need to invest, actually double down efforts on primary care, but also invest in improving the specialized services that hospitals provide. And that, again, all with the consigna and the spirit of the universal healthcare that Costa Rica offers the population.
So Andy, I wanted to bring, so that's a launching point. When I did my research, it kind of reminded me of Britain, where you had the majority was publicly funded, primarily government, and I would say 85%, but you had 15% that was for profit or private, and folks with some extra income or who didn't want to wait in line could bump up and then just receive services quickly. And that reminds me of England. I think it's Harley Street or Hartley Street. It's where they have the private docs there. So so you're agreeing with that assessment, right?
It's very similar. So people who have, well, let's just a couple of extra data points that are important to keep in mind. So these efforts of primary care basically have allowed Costa Rica to move from 25% of the population up now to almost 95% of the population has access to primary care. It has really improved in terms of access. It also has come hand in hand with a very low out-of-pocket expense that Costa Ricans pay per year. So just to give you a reference point, Costa Ricans pay less than $30 per year on out-of-pocket expenses. In the US, correct me if I'm wrong, but it's closer to $1,400 per year per person.
$1,400 would be a great insurance plan. For my kids, for my crew, my deductible's $5,000. So, I got to hit that. And
there you go.
That's fascinating. That's fascinating.
Yeah. So again, there are people who have, higher levels of income that don't want to go to the device, to the local clinic. They want to go to the private clinic. And again, this is this ongoing discussion for many years now, because then one, you have the issue of what happens with the data. Like if it's on a private provider, you're not necessarily connected with the device system and ERUS, which is the single medical electronic record that I mentioned. So there's an issue of data there, but it's also an issue of, well, is this allowing the country to really plan on how to go about with, again, providing specialized care when you have private sector providers that are doing it for people that can afford it? How do you balance those two things, right? That's a big challenge moving forward for our system.
That's wild.
Do physicians in Costa Rica feel like they're being fairly compensated, or is there, like the average physician in Costa Rica, are they frustrated with their annual income, or they seem satisfied, or you're not really sure?
Costa Rican physicians in terms of the public sector, you mean?
Yeah, someone goes through all that training, and this is the gripe here in the United States, that physicians are frustrated now over healthcare costs going up for the consumer, but physicians are not making more money; they're making less.
Well,
a lot of the money is going into private equity or a middleman or pharmaceutical industry. So I'm just curious in Costa Rica if there's that same frustration.
Well, I would say what physicians end up doing, first of all, there's a big difference in terms of the amount of resources that a physician in the US has to put in to go and get actually, the degree and actually go through that path. It's way more expensive to do that in the US than in Costa Rica. So once you graduate, let's say when you're ready to practice, you don't have as much investment done. That's one, right? So there's not that pressure to return that. That's one. Second, in Costa Rica, if you end up working in the private sector, you'll be fine. If you make mostly really well compensated. And the people who work in the public sector, it also depends on the type of hospital and the specialty, but in general, you can make a good living
Okay,
if
good.
you are a physician in the public sector. You'll be well compensated, and a lot of people actually have positions that allow them to do both, and that's what a lot of people end up
So it's
doing.
still
And
it's still an attractive occupation where
Yes, very much so.
you're getting
Very
people that go to
attractive.
school and dream of being a doctor and
Yes,
yeah,
nurse, and they
yes,
want to be in the healthcare field. Yeah.
yes.
absolutely.
So it does substantiate my statement that it's like the British system. So Andy, so another thing, just another really feather in the cap of the Costa Ricans is the literacy rate is so high.
Mhm.
And I wanted to talk about home-baked medical education and docs not having to go to, the United States or Canada or Britain or Australia or something like that to get educated. So Costa Rica has, I think there's 7 medical schools, is that right?
Mhm.
And they're all quality. And so a Costa Rican kid from high school, he applies, he gets into medical school, costs are low, so he's not under pressure to pay it back. Now in America, John, it's $250,000, $300,000 to pay back. And you haven't even gotten off the launching pad, so that's why people want to go into procedures to pay back their student loans. But so my statement is correct, Andy, that the teaching within Costa Rica is very good, and most kids don't leave but get educated within the country.
Absolutely. That is also a critical component of it. So now there are, let's say, I would say 5 main universities where specialists are trained in the country. There's the main one, for sure, is the University of Costa Rica, which is the long-standing public university that has a medicine faculty there. But there's also private universities offering this that have signed agreements and actually have accreditation with the Social Security system for the training of those specialists. So there's different pathways. Now, a big challenge actually has to do with the system not able to train enough specialties. That's actually our challenge. It's not a challenge of people not being interested or not seeing a career path or not being well remunerated. Actually, it's a challenge that is also linked with what I mentioned on the waiting lists that we have in certain hospitals for people to get specialized treatment. Has to do also with the bottleneck of how do we move students from the hospital level from the university level to the hospitals. So, but yeah, most of the doctors that we have in country are trained in Costa Rica and at a relatively low cost.
That's great. That's what I thought.
Yeah.
So this has been fascinating. Again, I think our audience is really going to enjoy this discussion. And again, the best kept secret will hopefully not be a secret anymore. But I learned a great deal. And yeah, so John, anything you want to add?
Oh, that was really wonderful. I mean, one thing that's kind of interesting, I was just crunching some numbers. So there's 7 medical schools in Costa Rica. There's around 160 in the United States. In Costa Rica, you said, had a population of 5 million people.
Yeah.
And the United States has 330 million. Now, obviously, we don't know how many spots are in each school, but based on that, you would think we really need a lot more schools in the United States per person.
Oh, so
I mean, now the thing is, you have to remember, the United States now they're training nurse practitioners, physicians assistants. That's one of the reasons, because in the United States there's a huge deficit of primary care physicians. We don't have enough of those.
I mean, not only that, ophthalmologists, John.
Yeah,
it's projected.
But there really are not enough primary care here. Whereas there, it sounds like they need more subspecialty. But it's, maybe I need to move to Costa Rica.
No, I think there's lessons to be learned from any healthcare system, obviously,
Right.
and there are no recipes, right? There are only like different pathways. But I think that there's one takeaway. It has to do with the way that Costa Rica prioritized primary care and these multidisciplinary teams of that include, and this is an important aspect, like I mentioned, the medical clerk, the nurse, but also a physician. And the combination of those roles working together and having a combination of services provided in the clinic, also with the technical assistance that I mentioned that does the home visits, that has able to, and that it has able to really put into practice the concept of equity, of solidarity, because back in the day when these were created in the 90s, that I mentioned, the EBI system was created in the 90s, it was prioritized by the regions that were actually the poorest and the hardest to reach. That means ATAPs, technical assistants, actually, when they do their home visits, sometimes they do that riding a motorcycle, riding a horse, riding an ATV,
Very
to
cool.
reach very far, far away places, but allows the system to reach the individuals. So it's very person-centered. It's comprehensive because, again, there's a nurse, there's a medical record, there's a physician, there's a pharmacist. It's a continuous because, as I mentioned, this is done year by year. It allows you to track through the age of people, and it's very, very well monitored. The whole monitor and evaluation of the system itself on the primary level has also been a core component of its success. And again, this has translated in its less costs, is very efficient in providing preventive care and treatment, which makes it less expensive because if you're already treating people with cardiovascular disease, that's very expensive. You're treating people with diabetes and other comorbidities. It's very expensive versus treating them on a preventive case by case. And you're also, the EBI's clinics are also promoting healthy lifestyles through talks like in local churches and trying to provide active lifestyles and nutrition. It's very comprehensive in that aspect. And again, these are relatively low cost solutions. So for other developing countries and for other countries around the world, I think it's also beginning to rise and to becoming to the focus of the critical importance of primary care as one component of healthcare systems, right? And I think, again, the Costa Rican case can be one example of how to do things. It's not the only way. It can be improved. Like I mentioned, there's challenges in terms of financing, in wait lists, in expanding the system because we're still lacking certain areas that are not covered by EBIs. So it's still a system that needs continuous improvement, but I think it can shed a light on how to, maybe in some parts of the US, systems like this can be better used to tackle some of the healthcare challenges.
No, it's brilliant. It's brilliant, Andy. And I do believe you're right that this model should be really this is a shining example of how to do it. And it should be adopted by other countries. The challenge in the United States is that we're heterogeneous and we're not small. But we have a lot of smart people. When a lot of smart people get together and they have a foundation of a model like this, I think you can make improvement. So yeah,
Yeah.
so great.
Just if people are interested in this, I'll tell you this. There was a big effort a few years ago, relatively recent, by an organization called Ariadne Labs. They are based in Boston, actually. And they did what is the most comprehensive research in English done for Costa Rica's primary care model. So if listeners are interested in exploring that, if you go to Ariadne Labs and their webpage, you can see a lot of documents that they created as case studies, as lessons learned about this Costa Rican model. And the person that now leads Ariadne Labs, his name is Asaf Biton. He has worked a lot on health systems. He's an expert in the area. He has done a lot of comparison of health systems across the world, and he was one of the individuals in charge of doing this work, and it's very comprehensive. I would highly recommend if you want to see data, more facts, the history of how the Costa Rican primary care model works.
You know, Andy, send me that and I'll put it on the YouTube recording. Send me that
For
link.
sure.
I'll get that on there. Fantastic. John, anything else?
No, it was wonderful. I don't want to bring up a whole can of worms, but just something to think about for the next discussion is malpractice there versus the United States. Because I think malpractice is a big driver of healthcare costs here, meaning a lot of unnecessary tests, a lot of preventative medicine. My guess, and you can correct me if I'm wrong, is are there as many attorneys suing doctors there with huge malpractice cases?
I don't have the data,
Yeah.
but my instinct would, and from what I remember, my instinct is that it's much lower. The issue
Yeah,
of malpractice.
that-
much
That's
lower.
one of the problems in the United States. It really
Yeah.
drives healthcare costs.
Yeah.
No.
So yeah, I don't. Again, we could discuss that but I
Yeah.
just wanted to bring it up.
Yeah. That's valid, John. That's valid.
Yeah.
Right. Very, very interesting. I didn't think of that, but valid point. But Andy, once again, thank you so much for being here. That was fantastic. I learned a great deal. Our audience learned a great deal. So we'd love to have you back. We can continue this conversation. We will, and I'll post the information that you just discussed on the page so that folks can dive deeper into the Costa Rican model, which I think is really prudent. But we're thrilled. Thank you so much for being here. Please like and subscribe, and we will see you on the next one.
Thank you very
Thanks.
much, John and Carl. It was a pleasure. Stay
Thank
safe.
you.
Andy.
Very informative.
Okay.
Bye-bye.